everyone. Thank you for joining today's Advances in Autism Research and Care webinar. Before we get started, I just want to review a few housekeeping items and let you know how you can participate in today's event. So right now we're looking at an example of the GoToWebinar attendee interface, which is made up of the viewer window on the left, which allows you to see everything that's presented today, and the control panel at the right. Within the control panel is how you can participate in today's event. So the control panel allows you to choose your audio mode. All attendees will be muted during the presentation. The control panel also allows you to ask questions, either using the questions pane, or you can raise your hand and be unmuted to ask a question. We'll address Q&A at the end of today's session, and just as a reminder, today's webinar is recorded and everyone will receive an email with a link to view the recording, the slide presentation, and an evaluation for CME credit after the webinar. So today we have 3 network investigators who are currently conducting secondary data analyses on the ATN registry under the AIR-P RFA 08. So we're going to go ahead and get started with Dr. Zamora.
Hi, good morning. I'm Irina Zamora. I'm a clinical psychologist, and I'm going to be talking about disparities in behavioral comorbidities and use of medication in children with a diagnosis of autism spectrum disorder. I'm pretty excited to get some feedback from the audience and to discuss the preliminary results. Okay. I think I'm having some technical issues with that. Thank you. So we have a team of collaborators that are currently working on this project. I just want to acknowledge their contributions. Okay. A little bit of background. We know that there are healthcare disparities across multiple domains, including access to care, use of services, quality of care in the United States. So we're very interested in looking at this. Also, children with autism spectrum disorders have mental health concerns that present many times challenges when provided treatment for them. Specifically, we know that minority children, including Latino families that have children with autism, have limited access to subspecialty care, and this is something that has been identified as challenges that these families have. There are also some challenges when it comes to the use of psychotropic medication, and there is a couple of recent studies, and one specific one looking at the ATN registry that Caucasian children with ASD were more likely to use psychotropic medication than Hispanic children. For this specific study, this study aims is a cross-sectional retrospective study aiming to explore the relationship between race, ethnicity, behavioral comorbidities, and use of medication in children with an ASD diagnosis that are currently enrolled in the ATN registry. And the children are 6 to 18 years of age. And what we looked at was baseline data. A little bit about the study's objectives. We want to identify the prevalence rates of ASD diagnosis among different ethnic and racial groups. We want to compare the prevalence rate of behavioral comorbidities among these groups. And we also want to compare the prevalence rates and type of medication used among these groups. For this specific presentation, I'm going to focus on 2 groups. I'm going to focus on the Hispanic group compared to the non-Hispanic white group. And I'll be presenting some preliminary findings. So for the sample, we have children with an ASD diagnosis, and we look at Asperger's syndrome, autistic disorder, pervasive developmental disorder. Our sample included 1,935 non-Hispanic white children and 255 Hispanic children. And we think that there is an underrepresentation, possibly an underrepresentation of the Hispanic children in the sample. So for the behavioral and medication categories, the way that we looked at, we used the CBCL, the Child Behavior Checklist, to look at different domains, including externalizing problems, total problems, ADHD problems, conduct problems, affective and anxiety problems. And we used the clinical cutoff as our cutoff as well. And we also looked at the sleep problems using the Children's Sleep Habits Questionnaire. For the type of medication, we extracted it from the medical form that parents complete at the time of enrollment, and we matched the categories with the behavioral comorbidities, and that's how we analyze the data. A little bit about the statistical analysis. We only included at this point only baseline data. We had some frequency distributions of the demographics, behavioral comorbidities, and medication use. We also had some completed some bivariate analysis, chi-squares, and t-test ANOVA to look at some of the variables. A little bit about the results. For the demographics, was interesting that at the age at the time of enrollment, the Hispanic children were slightly younger than the non-Hispanic whites. One of the things that I don't have at this point is the age of diagnosis, so I only have the age at the time of enrollment. And that's something that we're going to further look at. For the gender distribution for the sample, we didn't have any significance, so we had a similar gender distribution, one or two groups. Okay. For the educational level, the demographics, we found that for the primary and secondary caregiver educational level, the Hispanic group had a higher proportion of the families being with less than a high school education level. Additionally, when looking at household income, we found that the Hispanic group had a higher proportion of a household income of $25,000 and less for this specific sample. Okay. We're looking at results. For the prevalence rates of the ASD diagnosis, we found that to be significant as well. We're looking at these two groups, with the Hispanic having a higher proportion of being diagnosed with an autistic disorder and a pervasive developmental disorder. Interestingly, for the behavioral comorbidities, we did not find any significance between the two groups in any of the areas that we looked at. However, for the medication use, as you can see, we found significance in all of the type of medications when we match it with the behavioral comorbidities. So in our preliminary conclusions, we found that there is a higher proportion of Hispanic children diagnosed with autistic disorder and PDD-NOS than Asperger's syndrome. We also found the behavioral comorbidities were not significant between the two groups, but medication was significant between the groups. Some of the implication is that we're looking at the two groups having the same prevalence of behavioral comorbidities, the Hispanic and the non-Hispanic white children. However, there is a lower use of medication for the Hispanic group. And potentially this may be related to some of the challenges with access to health care for this population. And also, it could be related to some of the cultural some cultural differences in regards to the use of medication. You know, based on some of the previous research, we know that Latino children are more likely to receive fewer treatments, including subspecialty visits and procedures, when compared to non-Hispanic white children. So again, for our some of the limitations of the study is that results, of course, can only be generalized to children in the registry or children that are similar to those in the registry. The data also provides limited information regarding why these disparities exist in the medication use. So some of the next steps that we're thinking, the group is thinking about, is looking at some of the follow-up data. I'm thinking about whether looking at some of the disparities in medication use by analyzing the follow-up data in children that are enrolled in the ATN registry and are receiving subspecialty care. Okay. So one of the questions that I have for the audience with regards to the implications, I'm really interested in here whether there are other possibly explanations for this disparity, for these results that we got. And also, I'm really curious whether this is consistent with what you see in your clinical care.
So if anybody has any kind of thoughts on that question and you'd like to unmute yourself and share, then please feel free to do so.
Or if there are any thoughts throughout the end, maybe we can revisit this question.
You hear me?
Yeah.
Oh, great.
Yeah, go ahead, Brian.
Hi, Irina. Thank you. That was helpful, and you have some interesting findings. I wonder, though, given the audience we have today, whether we have enough clinicians on the call to sort of help think through this. But so we may, and I would encourage folks to speak up, and if they have questions or comments. But I was also wondering, Irina, if you can sort of just describe briefly sort of what your next immediate steps are as you wrap up your analyses for this project before we move on to the next presentation.
Yes, so we are looking at different, the race and ethnicity questions. So we are including other race ethnicity categories to our research question. And we have some preliminary data with that. We also want to explore a little bit more the impact of whether there is significance using the education level of the sample, as well as type of insurance and household income, if that makes a difference with the medication use.
Great, and we might be able to revisit this question at the end of the webinar as well. So we will go ahead and continue with Dr. Hallway.
Hello, I'm Jill Hallway, and I just want to go through the list of contributors. I'm the PI, and Eric Butter is the co-PI. We're from Nationwide Children's Hospital and OSU, Ohio State University. Andrea Whitwer is the LEND Training Director at the Neishunger Center, and Rebecca Andridge is our statistical consultant. And Dana Canera is our LEN trainee, and she's working right now on doing a lot of the data cleaning. And so our project is we're looking to characterize underserved populations, children participating in the Autism Treatment Network, and we're looking at disparities by assessing demographic influences. Okay, it worked. So most people know that early intervention has an impact on the prognosis of children with ASD. And in 1996, Rogers did a review of the literature of early intervention treatments and found that the children who were diagnosed between the ages of 2 and 4 and who got early intervention, their prognosis was much better than children who were diagnosed much later and had the same interventions. We've also, investigators have also found that children of lower socioeconomic status are less likely to be identified at a younger age. And Noel and Mazurek found that parent education had an association with early age of diagnosis and access to services. That didn't work. Okay, let me see. Okay. Others have found, and Mazurek is one of them, but Fernell found that their comorbid behavioral problems and psychopathology have an association and an effect on the age of diagnosis of ASD and also access to services. Mazurek and her group did an analysis with using the ATN registry data, and though they found that that parent education was associated with access to services and age of diagnosis, but they didn't look further. And in their limitations, they said further research should be done. And so what we're hoping to do is extend that literature and add a few more variables to look at. Let's see, I think I missed one. Let me go back. Okay. Yeah, that's the one I missed. Okay, so another group of investigators, Thomas, found that factors such as household income, parent education, and insurance status influence a family's access to services. And although this study was a good one, they surveyed 383 families in North Carolina. It was just limited to this area, so it limits the generalizability of the results. Now, we know that the Autism Treatment Network has had at one point 17 sites, now 14, across the country, and although it doesn't include the whole country, it broadens the generalizability of these results, and that's another thing that we hope to do with our study. Okay. Okay, we did that. Two study questions. Our first one is, our age of ASD diagnosis, access to behavioral, medical, and educational services associated with specific demographic variables. And the next one is, does IQ, autism severity, comorbid psychiatric disorders, and behavioral problems moderate the association between these demographic variables and our outcome measures, age of diagnosis and access to services? So our study is, and we're just starting to analyze, get ready to analyze, we're cleaning. Our study will look at participants of the ATN, their data, ages 2 to 17 years. They'll have an ASD diagnosis by DSM-4 and DSM-5, and this will be confirmed by the Autism Diagnostic Observation Schedule. Our dependent variables will be age of diagnosis, number of services accessed, so whether they get discrete trials training, applied behavior analysis, occupational therapy, physical therapy. We will look at all of those services. We'll also evaluate medication use, and we'll look at the complementary and alternative medicines that are accessed by families in the Autism Treatment Network. Our predictive variables are going to be zip code. We're going to be determining which children are in rural environments versus urban environments, and how this affects their age of diagnosis and access to services. We'll also look at household income. Now, a couple of these variables have been discontinued. So although we have a data set that has like 6,000 participants, zip code, there may be around 3,000, and household income is probably around 2,500. But we'll look at those as well as parent education, and we're also going to take it a little further and look at the groups that have private insurance as opposed to Medicaid, and how that affects their access to services. Okay. So our possible moderator variables are a level of intelligence, are the CBCL, the internalizing behavior, externalizing behaviors. We're going to look at the ABC irritability subscale and hyperactivity scales. We're also going to look at the symptom severity for ASD on the ADOS. And finally, the Vineland Adaptive Behavior Scale will look at communication skills, social skills, and adaptive behavior. So, okay, statistical analysis. So, I've worked in these in this data set before, and it's just wonderful. It's a wonderful wealth of information. We're very, very fortunate to have it and be able to utilize it. But there are areas where data are missing. So we intend to, right now, Dana is conducting frequency counts of all of our variables, and she is she's getting that information for us. We're building our data set, and we'll do missing data assessment in SPSS to see whether the variables are missing at random or not. And we'll SPSS provides a little chi-square, which will tell us the significance of that. We'll also be characterizing the samples, so we'll be using t-test and chi-square, Fisher exact to evaluate probably one-way ANOVA for categorical variables, but we'll evaluate the group differences that way. Now, I'll come back to this because I have a question about this. So when we proposed, made our proposal, the steering committee came back and said, you know, we think you need to do a propensity score analysis. This is not something that I had experience with, but I spoke with our statistician, Rebecca Andridge, and she explained to me that what we would do is dichotomize the outcome variables to evaluate group bias, and we would conduct a logistic regression, and that makes very good sense to me to look for these biases. But I had a question for the statisticians as to how do it's easy to dichotomize medication versus no medication, CAMs versus no CAMs, services versus no services, but how do we dichotomize age of diagnosis? Is there someone there that has an idea?
So we have a few of the folks from our Biostat Center on the call. I didn't know if any of you guys had an answer to Jill's question. And if you have trouble unmuting yourself, you could raise your hand and I can unmute you.
I mean, I think we could find it out. It was just something I was thinking about as I went through my slides, and as we start to go through this analysis, you know, I'll just need to know whether that's the right thing to do, to dichotomize age of diagnosis. I suppose we could go lower and younger, but I just didn't know. Sounds like nobody does. So we'll figure it out. Okay, well, we can move on. We're going to use a regression analysis, and I spoke with Rebecca, and she said that, you know, it might be good to start out with a simple linear regression, just to screen our predictor variables, and once we've got our predictor variables, then we might add them to a multiple regression analysis, and then figure out which would be our optimal model. Once we have our optimal model, then we would drop in our moderators using Hayes macro for SPSS. And that's where we're at. We're just getting into the meat of it, so I don't have information yet. I can come back later and give you more information, but if anyone, if anyone has some advice for us on our analysis, I'd be happy to hear it. And
Great, thanks, Jill. So again, we can kind of revisit all of our presentations at the end, and if folks think of some advice or some questions for Jill, then you can feel free to type them into the questions bar, and I can read them out at the end of the session, or we can always unmute you and let you ask directly. So if there are no questions currently, then we can go ahead and move on to Dr. Duncan.
Great.
Thank you.
Thank you. Okay, well, I'm Amy Duncan, and I'm a clinical psychologist at Cincinnati Children's Hospital, and I'm really excited to talk about some of the very preliminary results that we have from this project as well. So I'll jump in here. Oopsie. There we go. So just as kind of some quick background information, and I'll try to go through this quickly. You know, one thing that we know very clearly from a lot of the literature out there is that individuals with ASD really aren't developing the skills necessary to make a successful transition to adulthood. You know, a recent review of adult outcomes that was put out by Drexel in 2015, for example, found that 50% of adults with high-functioning ASD are still living with their parents and require significant supports on a daily basis. And other studies have found that, you know, depending on, you know, IQ level, anywhere from 55 to 80% of adults with ASD are not employed in full-time or part-time positions. So these are, you know, major areas that we're trying to figure out what skills are linked to them in order to potentially intervene. And one area is that studies have consistently found that adults with ASD who have better developed daily living skills are a lot more likely to attend college, be employed, and have more meaningful social relationships. And these daily living skills, you know, really what they are include skills like self-care, domestic skills. So I'll show you this next table shows really the Vineland, which is our sort of gold standard measure of adaptive behavior to some degree and is widely used, including in the ATN, really breaks down daily living skills into these three different areas. And so personal self-care, which really is focused on hygiene, you know, and as individuals get older, it gets more focused on kind of medical and health management. Domestic, which is much more focused obviously on sort of household tasks, so safety and awareness, but also cleaning, cooking, laundry, all of those types of activities. And then lastly, community, which is, you know, at younger ages, much more focused on time management, you know, basic awareness of money and what it is used for. And then as individuals get older, really looks at things that are higher level budgeting, you know, ordering your meal at a fast food restaurant, understanding different aspects of employment, like obeying time limits for breaks. And so, you know, these are skills, again, that have been linked to adult outcome, but we also know that they are significantly impaired compared to peers with typical development, but also peers with other developmental disabilities. So in studies that have compared, you know, individuals with autism to individuals with intellectual disability, we're seeing that individuals with autism typically have lower rates of daily living skills across those 3 different areas assessed. And then just kind of a quick sort of precursor to one of the reasons I'm really excited to be doing this study is Summer Bishop and I published a study back in 2013 that really only focused on it. It used the Simon Simplex collection, which is another very large data set, and it focused on high-functioning adolescents with ASD, so between the ages of 14 to 17. And we had 417 adolescents in the sample, and what we found is that about 50% of the sample with high-functioning ASD had what we called a daily living skills deficit. And we define that as having a discrepancy of 1 standard deviation, so 15 points, between your full-scale IQ and your overall Vineland daily living skills domain score. And practically, while it may not seem like a big number, but practically what that means is that for a 16-year-old, you know, if you have a Vineland that's 15 points below your IQ, you know, that typically means you're functioning more like a 10 to 11-year-old. And so that becomes a really big gap to close as you get older and older, and encompasses a wide range of skills that would need to be developed. And then, you know, some other pieces, what we do know is that daily living skills have been linked to variables like age and IQ, language skills, early intervention, autism severity. It's widely dependent, though, on different studies and different factors. And there haven't been a lot of studies that have used large data sets to look at this. You know, data sets like the ATN that have a wide range of different variables that we could look at to see what else might be related to daily living skills. What are things that other studies haven't assessed? And then interestingly, despite this kind of importance of daily living skills, there aren't any evidence-based interventions, you know, intervention packages for children or adolescents with ASD. We know strategies that have been shown to be effective to work on specific skills, but there are no intervention packages. So having a better idea of what variables are linked to daily living skills would really help us kind of tailor interventions and figure out what are going to be the important components of an intervention package that's looking to target daily living skills. So it's a very, very quick overview. And so what I'm aiming to do with the current study is really 3 specific aims. And so the first being that we're really going to look at the effects of various variables, so demographic variables, but also a lot of individual variables on the development of daily living skills using the Vineland. And then our second aim is really to determine if there are specific subtypes of daily living skills in children and adolescents with ASD. You know, is there a profile among those 3 different domains that the Vineland assesses that varies depending on, you know, again, those different individual variables? And then we'll also have the opportunity to look at the trajectory of daily living skills development over time in sort of a smaller subsample of children and adolescents who, you know, have been administered the Vineland in at least 2 time points. Okay, and so I, like Jill mentioned, I've been really sort of actively cleaning the data set and trying to get it ready for analyses, and have just really, my statistician and I, Ryan Adams, who is also here at Cincinnati Children's, we have just really started some preliminary data analysis and are kind of getting our feet wet in the data set. But so these are very preliminary, but we want to share these with you guys, and we should have a lot more in the coming weeks once we get things figured out. We also had the unfortunate all of our statistical licenses expired May 1st, so it's been a bit of a crazy thing getting all of that figured out over the last week or two. But anyways, so jumping back to these results, so you'll see that we've broken it up into these 3 age groups, and this is what I had proposed in the ATN proposal. And you'll see that obviously it's much more heavily weighted to younger individuals. And so one thing that we actually may do and kind of potentially touch base with folks at the ATN is kind of change up our age groups a little bit, because that 13 to 17-year-old age group only has 261 participants in it, and there's also not as many of the measures, the language measures, and some of the other things that are present. Even if we brought it back down to 10 to 17-year-olds, we could get have a chance to look at that in more detail. So these are just really basic sort of descriptive statistics, and you'll see, I think, kind of the couple interesting pieces just to pull out of just these basic stats is that, if you really focus on the Vineland Daily Living Skills Standard Score, and then within those 3 subdomains, their V-scale scores, which has a mean of 15 and a standard deviation of 5, you'll notice that, roughly they're in that 13 to 17-year-old age group, they are significantly lower than in the other 2 age groups. And so that's interesting, because it again kind of is another confirmation that there's a pattern that adaptive behavior does appear to kind of get worse in older age groups, that they're falling behind, they're not keeping up with that development as they're typically developing peers, or even peers with other developmental disabilities are. One thing that we're also going to potentially look at beyond just the standard scores and V-scale scores are actually the raw scores of the Vineland. So this is something in an intervention study that we're doing that is a daily living skills intervention study here. We've done a lot looking at the daily living raw scores and kind of seeing that obviously relates to the age equivalent. So that's a piece that we may pull into additional analyses as we go as well. And that's kind of a unique feature. There aren't many studies in the literature that look at raw scores and how those may change over time, or how they look across different age groups. So we're kind of excited to look at that. And then just wanted to kind of show some scatter plots that we did, really kind of looking at this relationship between age. And so this is the entire sample. This is not broken down into age groups. So this is really focused on 3 to 17-year-olds. And this correlation is significant, but it's 0.08. So, we're not seeing much of a relationship between age and, increasing that daily living skills standard score. And then similarly, this is the personal V-scale score of the Vineland, which again looks at hygiene and self-care skills. And this is not a significant correlation, and the correlation was very weak at just negative 0.03. And then when we look at domestic, interestingly, this is a much stronger correlation. So it's the correlation, the R is negative 0.26. And that was significant at less than 0.001. And this is sort of an interesting finding, because it's kind of is not something that we've seen found in the literature, to think that, again, as your age goes up, your domestic skills are actually getting lower, which may, thinking intervention-wise, that may be an area to potentially start in terms of teaching domestic skills like laundry and cooking and cleaning, especially in interventions with adolescents or older school-age children. And then lastly, the relationship between age and the community score was also significant. P was less than 0.001, and that was significant. The R was negative 0.17. And just the other piece that we've been looking at are some correlations to kind of get an idea again of you know, we're definitely going to do some regression analyses and, you know, also want to look at the trajectory of development. And so really what we're finding across these different age groups that we've broken them into is, so in the 3 to 5-year-olds, what we're finding is that as autism symptoms increase, Vineland scores across the board, both the daily living skills standard score, and then these are all V-scale scores here, personal, domestic, and community. Those are decreasing. We have a lot of receptive and expressive language measures, you know, from the OWLS and PLS, preschool language scale that we utilized. And what we're seeing, which again is kind of an interesting finding in the literature, that as language is increasing, so is the Vineland. And then also we looked at the ADHD T-score from the child behavior checklist and saw that as ADHD symptoms are increasing, the Vineland skills are also increasing. So some potentially interesting findings looking at those younger kiddos. But when we looked at 6 to 12-year-olds, it is a similar pattern in terms of the linkages with autism symptoms and receptive and expressive language, but there's no relationship with the ADHD, which is something that, you know, we had been hypothesizing here just for that executive functioning piece, potentially, that could be something that would be linked to, you know, the less executive functioning impairments you have, which are often, you know, associated with ADHD, the more likely you are to have daily living skills in general. And then when we looked at our oldest age group, so we didn't have enough, only 4 of the over 200 participants had receptive and expressive and overall language skills, so we couldn't include that in our correlational analyses. But what we do see similarly is that the Vineland is highly linked to you know, their autism symptomatology, but we're not seeing as much of a linkage with their you know, ADHD symptoms. And so really our next steps is we're continuing to kind of clean the data set and add to it, especially adding in those different demographic variables. So we are going to look at race and ethnicity, you know, parent education, as well as socioeconomic status, and also looking at, you know, also pulling in some of the other subscales from the CBCL, you know, in particular anxiety, which has been linked to daily living skills in one study, to see if that has any correlation with any of our age groups with daily living skills. And then we're going to be doing a lot of analyses in the upcoming weeks to really look at AIMS 1 through 3. And then our other last steps, we plan on meeting with the Family Advisory Committee to discuss some of the results and implications here at Cincinnati Children's and get their thoughts on, you know, why some of these things may be going on and kind of get a discussion going there. And then obviously drafting some manuscripts and preparing abstracts to present at conferences over the next year. And that is all. Oops, sorry. So I will stop there.
Great, thank you. So if anyone has any questions for Amy or any of our presenters, we have plenty of time to answer some questions. It doesn't look like anyone has any questions right now. I guess if there are no kind of immediate questions from the audience, if any of our presenters have any final thoughts, we can wrap the webinar up early, and the slides will be sent around as well as the recording. So if folks have questions later on, then you can always email them into the AIR-P and we can send them to the presenters. So I guess I'll open it up if any of our presenters have any last-minute thoughts or questions or comments. All right, I guess I will take that as no comments or questions from anyone on the call, so we will go ahead and wrap things up a little early. Thanks everyone for joining. Just a reminder that an evaluation will be sent around after this, and if you do have any additional questions for our presenters, then you can always email them and we can put you in touch.
Great.
So thank you
so
joining.
much.
Thanks to our presenters, and have a great rest of your afternoon, everyone.